and I'll be your host and moderator for today. Before I introduce the panelists, I'll just give you a little background on this new series and go over a few housekeeping items. This new series is designed to provide insight into the challenges and opportunities in pharmacy for current and prospective students, as well as the training and practicing pharmacy workforce. We hope to build a community of stakeholders interested in exploring the quandaries presented for pharmacy practice and education in the current healthcare landscape, and to focus on the potential for pharmacy students, faculty, clinicians, researchers to drive positive change as science, business, and healthcare adapt to meet the needs of the communities they serve. We plan to host one or two more of these in the spring semester, and I welcome each of you to share your ideas for future topics in the post-event survey. So today's program is on community pharmacy, ethical dilemmas and opportunities. And our goal is to help you recognize the ethical challenges and opportunities faced in the community or retail pharmacy industry today from a variety of perspectives. The average American adult takes 4 prescriptions, and over 151 million Americans take at least 1 prescription. With an aging population, demand will continue to grow even as a nationwide shortage of retail pharmacists impacts the nation, and as late career pharmacists retire and early career pharmacists leave the field. Pharmacy school enrollments are also down 60% from 2011 to 2021. So with so many Americans needing medications from retail pharmacies, we decided to begin this series with a candid conversation about the ethical challenges pharmacists face in this industry. This program is being recorded and will be sent to all the RSVPs as well as posted at the CU Center for Bioethics and Humanities website. If you have questions for the panelists at any time, feel free to use the chat, and we'll open to audience discussion later in the program. Malia Himber and David Weil from the Center for Bioethics are available to help you in the chat. Finally, I'd like to thank the faculty and students on the planning committee. Their acknowledgements are in the chat, and Malia will post planning committee names as well. So with that, I'd like to briefly introduce today's panelists. Dr. Hannah DeVore is a senior pharmacist at Southcentral Foundation Pharmacy in Anchorage, Alaska. She grew up in a small town in Georgia and began her pharmacy career in the fall of 2010 at the local Walmart pharmacy, working as a cashier, slowly working her way up to pharmacy manager over many years. She completed her PharmD in Vermont, then moved to Alaska to work retail with Walgreens. In her current work as senior pharmacist at Southcentral Foundation, she thrives on the challenge to understand things deeply and fully believes that a good pharmacist needs to be a champion of lifelong learning, seeking new things to learn and ways to serve their patients. Dr. Angie Peterson is the co-chair of the Colorado Pharmacy Society Workplace and Wellbeing Taskforce. She graduated with her Doctor of Pharmacy from Belmont University in Nashville, Tennessee in 2020. She previously held managerial positions at 2 different pharmacies. Currently, she holds the role of pharmacy manager at Flatirons Family Pharmacy in Longmont, Colorado. In addition to managing the pharmacy, she also plays a crucial role in running clinical programs on the wellness side, further demonstrating a commitment to improving the health and well-being of the community with a passion for advocacy. Dr. Cody Taylor has been practicing pharmacy since 2014, and since 2016 has managed Valley Pharmacy in Colorado City, a rural community with a population of 2,200, where he also lives and enjoys raising his family. He takes great pride and finds immense satisfaction working and serving in a small town. And like many in his community, he's an avid outdoorsman. He says, as a community, our families grow together. We share and bear each other's burdens, the good times and the bad, health and illness. And finally, Dr. Robert Willis is the manager of corporate and pharmacy learning and development and is the residency program director for Albertsons Company's Denver division. He graduated with his PharmD in 2007 from the University of Colorado Skaggs School of Pharmacy. Dr. Willis practiced for 6 years as a highly engaged community-based pharmacist and became board certified in ambulatory care. As a community-based pharmacy practitioner, he was an early adopter of MTM, travel health, and point of care testing services. He also helped implement diabetes management, medication administration, and smoking cessation services in the Denver division. In 2014, he established the Safeway Regis University PGY1 community-based pharmacy residency program, and he's an active member of Colorado Pharmacist Society, where he served as president in 2021 to 2022. So with that, I will open the discussion with our first question, and this is for each of the panelists, and you can be brief here if you'd like, but I'm interested in what is the most challenging ethical dilemma you have faced and perhaps still reflect on in your work in the past year. Someone can jump in, or we could start with Hannah, if that's okay.
That would be fine. Mine, I would have to say, is not within the past year, but just over the years with working in retail pharmacy. My main goal as a pharmacy manager at Walgreens was to try and build that community pharmacy where people felt comfortable coming and speaking to me. I did find the major issues with that. People did see you as a friend, and when you were, faced with the problem of, I need my controls filled sooner, or like my control medication, it was stolen. One in particular, I had one patient, she was every single month, she got her medication. She was never early. She never came in. She never asked for it early. And then all of a sudden, one day she's coming in asking for her meds early, talking to her about it, telling her, possibly needed a police report because she said it was stolen. She started crying, and it actually ended up being that her daughter had stole her medication, and she did not want to press charges against her daughter. Seeing as how, she had never filled early, never asked, never requested this before, it was something that we did do for her. But you do run into, those specific ethical dilemmas, I guess you could call them, with, having customers that see you as a friend, with having patients that see you as someone that they can go to with their problems and everything. So building a community pharmacy it's important, but you also have to know your boundaries and be able to follow those boundaries.
Thank you. Yeah, relationships beyond the professional one. Who could go next? The order I have is, Dr. Peterson next, but.
Yeah, I'll go ahead. So, I graduated in 2020, so I was immediately thrown into the pandemic. I worked at Walgreens initially when I first graduated. And so with that, when the pandemic came out, or started, we didn't have a vaccine, we didn't have any treatment. And so that led to people reaching for any and all possible treatments. This, we know, led to ivermectin and hydroxychloroquine. So when I was at Walgreens, I typically denied any and all of those prescriptions that weren't being used for an FDA approved usage. And then about a year ago, I started in the position that I am now. I'm at an independent pharmacy, and we compound ivermectin very frequently. And so when I first went in, I thought, there's no way I'm not doing this. I always have denied these ivermectin prescriptions. But one, it's a very small business. I'm not the owner, and it brings in a lot of revenue. So I had to maneuver around dispensing that medication while not agreeing with it. And so to make myself feel better and do my duty as a pharmacist, I just make sure to continually counsel them, have an unbiased opinion, which can be hard when you don't agree with something, but it's just, I stay with counseling them on the side effects, any signs of toxicity that they might have, so that I'm still able to deliver that good patient care to them, even though I don't necessarily agree with the treatment.
Yeah, I think it's a great topic, and maybe we can talk a little later about this issue of balancing, your professional obligations or fiduciary obligations to the business with, your obligations to evidence-based medicine and your own conscience, right? And so. Dr. Cody Taylor.
All right, thank you very much. And I definitely see and experience both of the concerns that both Dr. Peterson and DeVore have mentioned there. In addition to those, I think in our small town, not just particularly my pharmacy, but within 20, 30 miles of us, all the pharmacies are considered rural, even though the town's a little bit bigger. And the biggest dilemma that I've had in the past couple years has been watching pharmacies close when they're stated to be open and not be able to fulfill their posted duties, fill prescriptions, just because they are so short-staffed, and pharmacists have walked out and they have just had to close their doors when patients' insurance only requires them to fill out those pharmacies and their prescriptions now stuck there. So the big dilemma that I have, and I think we might touch on this later, is the overall reputation of pharmacy right now, and my role, the state board's role, and the pharmacy school's role in maintaining our reputation. That to me is the biggest of all the concerns that I feel right now.
Great, thank you. Dr. Willis.
For me, a little bit different. In my role, I'm more of an administrative. So I was thinking over the last year what kind of ethical dilemmas, but I think they're applicable in the any pharmacy practice setting. But we did have some new leadership come, and someone who was established on our team was actually talking very negatively about our new leadership to other senior executives and VPs, making our department look bad. So I was kind of put in the middle. I knew this was happening. Who do I tell, right? I have a history with the person that was spreading the gossip, if you will, or sharing some of those things with that individual and not necessarily with the new leadership. So that was definitely a unique position that I was put in. Like I said, different than the other examples we've shared. But in that particular instance, right, I had to make a decision, what's the right thing to do. Essentially what I did is with that new leadership, without so many words and not divulging who it was, kind of shared that this poison may be going out there so that they could be, on their end when they are talking to these senior leadership individuals, know that that bias may already be there with it. So that's with my current position. There were other times when I was practicing in the community pharmacy, a lot of the same examples that we've talked about here with filling controlled substances early and things of that nature. With hormonal contraceptive prescribing, something that was kind of brought up, and we've been looking, thinking about, human trafficking and things like that. What kind of questions can we ask if someone comes in for, hormonal contraceptive prescribing, and making sure if, you kind of get that weird feeling, what does that look like? I will tell you, as an organization, we don't have the solution for that yet, but that is definitely something ethical that, in the community pharmacy setting, you could possibly see.
Great. Yeah, so I think a couple of those questions centered on this issue of, when a patient presents or requests something that maybe concerns you from a conscience perspective, or perhaps from an evidence-based medicine perspective. So maybe we could talk a little bit more about that topic. So, in what ways Dr. DeVore, Dr. Willis, you could expand, and the others could add their experiences. In what ways has this issue of maybe conscientious objection come up for you? And then also we could think about, in what ways should community pharmacists practice conscientious provision, right, as a means of improving access and addressing equity. It's not always going to be about, putting up barriers to access, but maybe somehow expanding access in a way that's not required of you in your role. And just jump in, whoever. I don't.
I can start. I practiced in the Denver metro area. So for instance, my staff pharmacist did not feel comfortable filling any medications related to, abortive procedures, if you will. So he felt very uncomfortable with that, but we did have a Walgreens a block away, King Soopers a block away. But I can see that being a challenge in more of our rural areas with that. It was very interesting though. We had overlap one day. Someone was filling a prescription for that and he was like, well, I'm not going to fill that. And I was like, we had overlap. I was like, well, I will fill it. Not a big deal. With that, and he actually made him stop for a second. And he ended up at the end of the day, of course, filling it because he knew, he was going to fill, I was going to fill, the patient was still going to get it. Of course, that was his own ethical dilemma or, his choice, what he wanted to do, but that access was still there for the patient. Like I said, so luckily we didn't really have any challenges at my particular location regarding that, just because we were in the Denver metro area, but I could see that being hard in a more rural area.
I can further prompt here because I do see how this issue might interact with the issue you raised, Dr. DeVore, about building these personal relationships with patients and consumers, and how that could interact with conscientious objection or provision. And so, yeah, I mean, those of you who work in the rural setting, Dr. Taylor certainly, and perhaps you also, Dr. DeVore, around Anchorage, your thoughts on how, to what extent is it appropriate to have these relationships with patients beyond, them as patients, and, the benefits and risks that might come with that.
I can speak on that. With Anchorage is like the biggest, smallest city I've ever been in. Everyone knows everyone, it feels like. A certain instance where I had an issue filling a prescription, I had a doxycycline for a CO who was in her 3rd trimester. Was not wanting to fill it until I spoke with the provider. Her mother was very gracious because she was the one that was picking it up. However, when her daughter called back, she was not very happy with me that I would not fill the prescription until talking to the provider. That was not her OB. It was one of those teledocs who just making sure that they knew everything that was going on with her. But anyway, so being able to talk to her mother, she was very, appreciative of that. We did end up getting everything changed for her to where it actually fit what she needed without going into too much detail. But being able to step back and be like, no, I'm not going to fill this prescription for you. And I understand that it's an antibiotic. It's a little bit different than, filling birth control or even dispensing needles. There is a huge heroin issue in Anchorage, and that tends to come up a lot as well here, to whether or not do you dispense the clean needle if they're going to be using, that they're going to be using. So would you rather them have a clean needle, or are you worried, if you don't dispense it, is that going to keep them from getting it? So that's another issue that we run into in Anchorage a lot. So we would have some pharmacies who would refuse to fill the syringes or the insulin needles for these patients that were coming in, but then also that puts more work on another pharmacy if you're refusing to fill it. So you kind of have to do that balance there. But I feel in Anchorage, there was always at least a pharmacy close by where I worked. There was one directly across the street. So if someone there refused to fill a medication, they could very easily come to Walgreens to get it. Within the area that I worked in, there were 4 pharmacies very close together. So just as long as you're pointing them in that right direction of where they possibly can go to get the medication or the needles or wherever they may, need to get them. So.
And I'd be happy to share a story if that's all right. Last fall, one of our patients, a cancer patient who we fill a considerably large amount of narcotics for, was in the hospital dying of lung cancer. Her son couldn't get a ride to Denver. I had to be up for a pharmacy conference. And I said, I'll take you up, no problem. And on the way up, right along those same lines, he tells me after talking the whole way, Cody, I'll be honest with you, my mom, his exact words were Vicodin junkie. And every month she's out of her medication within 2 weeks and is withdrawing till you fill it. And I just remember thinking to myself, gosh, I assume this, right or wrong, I assume this about a lot of our patients. I've never assumed it about her. The irony is she didn't pass away and she made a recovery. And here I am filling her 180 Norco tablets every month. So it kind of put me in a hard spot. But what do you do? I mean, pain's subjective, and it just put a wrench in the whole system with that little bit of knowledge of what I assumed and what we worry about, because we know this happens with a lot of our patients. But I don't want to fall into that trap of profiling and assuming one patient to the next is legitimately needing or abusing the medication.
Just to add a little snippet, I don't necessarily have a story, but I mean, conscientious objection. At the same time, we have to remember as pharmacists, we took an oath. And whether that means, if you deny a prescription, you still, to me, need to make sure that that patient is able to get access to that care somehow, some way. I think that's one thing that's always in the back of my mind is I took an oath for my patients, for the profession, for the community. And so you still need to make sure that, that patient has access, as well as, education, unbiased education as well.
And one other thing I thought of, another example I had when I was practicing, is one of our regular patients, right? They were in the pharmacy 3 or 4 days a week. They filled about every 4 or 5 days 9 tablets of Imitrex. They were obviously dependent on it. What do? They're your regular patient. It was a mom and daughter. The mom would call it in one time for hers and then the daughter. And so, after a little while, finally, I ended up intervening, right, and saying, hey, kind of what's going on? Let's see what alternatives we can have, to kind of pull you off of, using it all the time. But that was kind of hard because I knew them. I knew about their kids. I mean, actually, this year, even I haven't been at that pharmacy for about 5 years, but got a invitation to her daughter's graduation from high school, right? Because I knew her when she was young. So that's just an example of, it's great to really get to know your patients, but sometimes that can put us in weird predicaments.
Yeah, to follow up on that topic, and Dr. Taylor's comment made me think of this, where you might know several members of a family, right? I can imagine situations, where this can help you improve care, right? Like you learned something about your patient from her son that you didn't know previously. But are there also, difficult cases where perhaps, maybe in a rural setting, right, someone comes in and is filling a prescription for some sort of STI treatment, and you happen to know this person's spouse or partner or girlfriend? And are there situations like this that, raise some dilemmas for you around patient confidentiality, and or maybe it doesn't raise a dilemma for you there, but it just creates, difficult interpersonal situations for you where you feel like you have to hide something from someone else you do have, a close personal relationship with? I don't know if there's any anecdotes or thoughts around that topic.
I'd love to share a quick thought. We've been trained to, even when that arises and there's that close connection, to maintain confidentiality and to do our due diligence despite what's going on in the close relationships. But we have had a couple incidents in the last 5-6 years where maybe a technician, our community is so small and the technicians live in the towns too, where there's been claims that they've disclosed information and shared information about some of our patients, which fortunately we've been able to debunk, as far as I could tell, that, wasn't truly disclosed. But yeah, absolutely. When it's this tight knit and everybody knows everybody, it's hard, it's hard to control our tongues and to maintain confidentiality. That's true for anybody. But just as we're speaking and discussing this, that maybe the staff members, maybe the clerks and cashiers that don't have the HIPAA training as extensively as we do could use that to ensure that those problems don't arise.
I'll chime in. I think definitely HIPAA training, even for the community to realize, I mean, not necessarily training, but education. To realize, you know, once your kid is over 18, I can't tell you these certain things. I worked in a college town, both in, you know, in Nashville and when I worked at Walgreens in Greeley. And there were several times where parents were calling in, either asking about their kids' medication, asking for a refill, which is fine on the refill. But it was difficult. Like, they just turned 18, they just went to college. I'm sure their parents are concerned, but at this point, I can't tell you certain information. And typically when I was talking to parents or family members, I would ask just in general, open-ended questions without giving out information. If they were calling in for a refill, I would ask them what medication needs to refill versus saying, oh, does your daughter need their birth control filled? So that I'm not giving out that information. But it's definitely hard in a college town and in a rural town, like Dr. Taylor said.
I would like to add, you know, being a pharmacist, you know, and a patient comes to pick up with a prescription and they ask, you know, does my wife have any prescriptions? We know the medications, so any of that would be questionable, right? We are, of course, probably going to watch HIPAA a little bit closer than maybe a Tenolol or something like that. But just keep in mind, your clerks, your techs, they may not have that level of education to know. So I think sometimes, I'm just thinking back when I was a tech with HIPAA and things, I think almost if you are talking to your techs about HIPAA, reminding them of some examples of why, you know, that there are certain medications out there that the tech may not be aware that could be for, you know, an STI or something like that, that, you know, that's why HIPAA is so important. You know, and, you know, even if they think, oh, it's not a big deal, the husband and wife always pick up medications for each other, just to kind of stress that, give some examples of the why, and then hopefully those individuals will be, you know, will be abiding by HIPAA a little bit closer when that happens. Actually, one of my good friends, it was a technician at a pharmacy, not our pharmacy, but the technician, the dad was picking up some medicine. He said, oh, is any prescriptions for my son who is over 18 picking up prescriptions? And the technician's like, sure. Well, happened to be that it was the son's PrEP therapy. The dad had no idea that the son was on it, had no idea. It forced his son to come out. So, you know, just some example stories like that can happen. So I think just stressing that importance, that those individuals, you know, the technician didn't know, right? In theory, of course, HIPAA and all that kind of stuff, but maybe stressing and sharing some of those stories will help them abide by HIPAA maybe a little bit closer when they don't have as much education as we do regarding the meds.
In a similar situation here in our pharmacy, we have a husband and a wife where the husband is on Suboxone for treatment, and he's in his late 60s and has been for years, and his wife doesn't know, and he doesn't want her to know. And despite the notes and all we can do to make sure if that prescription is ready for him, that the wife doesn't know. We all know the family dynamic so well that even if you miss a note or if you're at the checker, we are able to maintain that confidentiality. So I guess the tightness and our knowledge of that family dynamics is helpful in that scenario.
Yeah, it's a good point that the close relationships can actually help in these cases, as opposed to be a problem. Yeah, if there weren't other thoughts on this topic, we could change gears a bit, but I think that was great. You all had some, actual suggestions for how to address these concerns, which is helpful. The topic of closures came up in one of the introductions. I'm forgetting exactly which one. So I figured I'd ask a question about that. This is a topic that has been in the research literature quite a lot recently. Right? Researchers have shown that retail pharmacy closures and pharmacy deserts are more likely in urban areas that serve disproportionately Black and Hispanic or Latino populations, as well as low-income, publicly insured and uninsured populations. And then in rural areas where independently owned pharmacies are more common, these are also the most likely pharmacies to close. And so clearly these closures have implications for equity in healthcare access and outcomes. And so from each of the panelists, you know, as far as they're able and willing, I'd be interested to hear perspectives on both what are some of the causes of these closures from your perspective in your work, and what are some of the effects of these closures? How do the closures affect both patients and staff? So both sides of that, causes and effects, if you're willing.
Here in Anchorage, we have quite a few right now Walgreens that are closing. It's been about 2.5 years since I worked in the retail setting at Walgreens. And when I left, we didn't have closures. It was very, very rare for a pharmacy to close at any point in time. We always had pharmacists that were there. And then the past 2.5 years since leaving, there have been numerous closings, to the point to where the pharmacy hours have even changed, to where some of the stores are not even open on weekends, to where they close at 5 o'clock instead of 9 o'clock, because they simply do not have a pharmacist to come in. And in the terms for Walgreens, you could fight it both ways. There are pharmacists in Anchorage. I feel when they talk about the pharmacist shortage, that it's not really more of a pharmacist shortage as it is the work conditions that they face in the retail setting. With that being said, the issues that I could see arising from that is, I know how busy it is when I open in the morning, or when I would open in the morning, and I closed at 9 o'clock the night before. I cannot imagine being closed for 2 days and coming back, and how many prescriptions there would be to fill, how many there would be to type. So it just is, it's compounding, it is adding, it is constantly just getting worse and worse and worse. So the more days that they are closed, the more times that they are closed early, the more problems that it's leading up to. It's more of putting the stress on that pharmacist, putting the stress on that staff. And then, you know, the technicians, it might not be their career. There's a huge turnover in Anchorage and Alaska in general, because people come up, they think, oh, I'll come stay for about a year or two. Sometimes they don't even do that, especially with military. We have a huge military base up here. It's a joint base with Elmendorf and Richardson. So we have a lot of turnover between military families. Military wives come in, want to work as a technician for a little while, and then they up and leave when their deployment is over. So actually getting someone in there who can stick around for a while and be trained and is comfortable with these conditions that, you know, they might be working in, is also difficult as well. In terms of the patients, the stress that puts on them. If you work until 5 o'clock and your pharmacy is closed at 5 o'clock, when are you going to pick up your medication? So some of these people, or excuse me, some of these patients are going without their medication. Some of them are delaying treatment and antibiotics for their children because they simply cannot get to the pharmacy before it is closed. If you need it transferred, the pharmacy is not open for it to be transferred, then you run into the issue of your provider having to call it in, and then it's already billed under your insurance. So then you're having to pay out of pocket. So with the pharmacy closures, I see so many issues with that. And just in general, better working conditions and top notch could definitely help with all the way around, I feel.
I'm sure we all agree with that. And I'm in Southern Colorado, and everything you said word for word. Luckily, not at our particular pharmacy, because we're more semi-independently owned and have the flexibility to adjust hours, hire PRNs, get people in to help. The big staff stores or the big retail stores aren't able to do this. The exact same closures that you mentioned, we see here. And I just want to, in my opinion, what kind of fueled this is a few years ago, when I graduated 10 years ago, and when we graduated, we had multiple offers, and the pharmacies were eager to hire us on as the boomers were retiring. And a few years ago, it seemed like we met that demand. And in our particular area of Southern Colorado, the retail pharmacy started to lower pharmacist wages, and pharmacists stepped out. And despite efforts and now sign-on bonuses the last 2 years, they cannot get pharmacists to come back in. And it's not now, in addition to the lower pay and then trying to get them back, it's primarily because the conditions are so bad. Multiple pharmacists that I talked to in our closest town, which is called Pueblo, describe going to work in the morning as entering a hellish environment. And who wants to do that? I mean, that's not why any of us got into this career, is to hate our jobs and to work in a profession where people are delayed their medications by hours or even days when there's closures and when there's 300, 400, 500 prescriptions behind in the queues. So I totally agree with everything you said, and I imagine most of us would. Dr. DeVore.
Yeah, workplace conditions is obviously a passion of mine, since I'm the co-chair on the CPS task force for that. I think that's definitely a reason for big chains closing and decreasing their hours, is we just don't want to work in that environment anymore. I worked at Walgreens as a technician, pharmacy intern, and then a pharmacist, and just watching how much things changed. Of course, workplace conditions were awful before the pandemic, but the pandemic kind of seemed to catalyze that per se. Now, as far as independence, like Dr. Taylor said, I'm at my independent, I have a great work-life balance. We're not short-staffed. I don't dread coming to work every day. I'm not working 13-hour, 14-hour shifts anymore. So then that is okay. Why are independents closing? Well, I think a lot of that might be payers, PBMs. We also compound at my store, and that's the revenue that we get on one compound is equal to almost 10 commercial items. We go anywhere from losing hundreds of dollars for filling a script to, of course, there's profit in some prescriptions, but sometimes it's 5 cents, it's $1. So independents have to become very unique in how they're going to get that revenue, which, like I said, for us is compounding. And then there's you enter that competition with other independents and other compounding pharmacies. And then when that ends up closing, whether it's an independent or a chain pharmacy, these patients are stuck, trying to figure out where to go. It's all of a sudden a scramble. Maybe they don't get their meds anymore. Like Dr. DeVore said, when they close early or just completely close, they just decide not to get their medications, that adherence goes down. And then it pushes a bunch of work onto pharmacies that are open, and becomes even more overwhelming to those other pharmacies.
I agree with what everyone has shared. The additional thing I will add is, with the reduced amount, that we're getting paid for filling prescriptions, I know a lot of organizations will look at, well, what can we control? So I know a lot of organizations, they'll do more structured around, compliance, trying to reduce chargebacks, right? When the PBMs come in and they audit your prescriptions, and, if you don't have the right day supply, things like that, but that does take time and effort to do that. Individuals in the pharmacy doing self-audits as well. I know one of the big ones, DEI charges, chargebacks, that's, hit, I know the large organizations really, really heavy, no transparency regarding those. So we don't even know how to combat those, but all of a sudden you have this huge bill to pay. But I will say, even before all of that, when I was a pharmacy manager, that was before DEI, they were still cutting staffing hours as well for our technicians and things. So I get it, it's a business, so at the end of the day, right? But it is kind of a hard place. Or, like I said, I think there's no magic answer out there. Otherwise, right, we'd be super rich with that answer. But it is definitely a hard place that we're in right now. As we're great opportunity to expand pharmacist role in practice, but the current conditions that we're in does not make that super, super easy.
Yeah, following up on that comment, Dr. Willis, the role of pharmacies has expanded a lot, right? I mean, pharmacies offer vaccinations, point of care testing, chronic disease medication management. It's not just traditional dispensing roles. And patients visit community pharmacies more often than they visit their primary care providers, typically. Also, there's this expected physician shortage. Also now, right, potentially a pharmacist shortage. But right, for these reasons, people tout community pharmacies as one way of improving health and addressing inequities in care access. But is this expanded role possible, right, given the workplace conditions you're describing and these closures and all of these stressors? And more specifically, I'm wondering if you all have any perspective on what policies could help balance the needs of pharmacies, right, with the needs of patients and communities, right? How can we realize this expanded role for pharmacies in a way that works for all the stakeholders?
I can jump in real quick. At our organizations, our pharmacists prescribe 12 to 15 different medications. And I like to describe it, I do new hire pharmacist training as well. Of course, they're excited, right? You get to prescribe medications, but right, it's like we have this plate that's overran with all this stuff we have to do. And now we get to do 12 or 15 prescribing services. I think it's all in your outlook. But, kind of like Dr. Peterson was talking about, those prescribing services, the amount of time you do, more ROI on that versus if you're filling a prescription with it. So the money's there. It's just I always tell my pharmacists, it's a really hard spot right now because what I would love to see, right, we have all this stuff on their plate. We've added these prescribing services. Now, what can we take off that plate for the pharmacist? I know for instance, in the state of Idaho, they also do pharmacist prescribing. And as they were doing that, they, have advanced the pharmacy technician's role. And I know here in Colorado, we've also been kind of looking at that. So I think, not a possible help to that is, continuing to expand the pharmacy technician role. What could administrative tasks that maybe historically has been a pharmacist, does that have to be a pharmacist? So for example, in Idaho, in select community pharmacies with specialty training, they do tech check tech. So with our computer dispensing system, we do a data verification piece that has to be done by a pharmacist, but the product verification, making sure the right tablets got in the bottle, that can be done by a technician with special training. So that kind of takes one step away from the pharmacist there as well. So, looking at the technician's role, they're also there with us. But then, of course, we get into the pay rate of our technicians and all that kind of stuff too. We're adding more stuff to them. And then I would love to tell you that, we're bumping their salaries like crazy, but unfortunately we're not. But I think, advancing the technician's role could definitely help that, because I know our pharmacists, at least, within our organization, even though they, have so much on their plate, they're very excited to offer these new services. Obviously, some more than others, but it is, they've really embraced it. And I think that that's what we need to continue, to change the perception and the landscape of our community pharmacist.
So to answer, I agree with you, Dr. Willis. And to answer your question, can we handle what's coming with current conditions? No way. There's got to be change. And I don't know how to make I've heard rumors that in other states, there's even regulations from the state board that per so many prescriptions filled, you have to have so many technicians or pharmacist hours. And I don't know if it's just exceptionally these last few years that have fueled this so heavily that, and I've said it for our reputation and the level of care that we're able to get to our customers, whether it's us as pharmacists, state board, or the schools of pharmacy working together to get back to something we can be proud of, something we can enjoy. And we do here in the community, in these small, more independent pharmacies. But geez, for all those that, like I said, we all talk to our colleagues a lot, and this great displeasure and frustration in the workflow. I would assume that's why the numbers are so low with the applicants to the pharmacy programs. It's not very appealing.
I would have to add possibly looking at the metrics that a lot of retail pharmacies have as well. When I worked at Walgreens, I feel like there was a metric for everything. How long did your phone ring? How long did it take you to verify this prescription? How many waiters did you have compared to everything else that was going on? And I feel like sometimes you can get so bogged down with worrying about what your metrics are that you forget what you're there for. You are there for the patient. You are there to make sure their medication, one, that it's correct, one, that it's the correct treatment for them in general. Not only just the correct pills in the bottle. You're there to answer questions, to be able to do that, and to be worried about, oh, when my district manager comes in, what is my phone hold time going to be? It's stepping away from some of those metrics and simply letting the pharmacist do their job and take care of the patient that is there in front of them could be huge as well. Put them on the front of, this is what I went to school for. I am here to help you. I am here to answer these questions for you, and not worry about, oh my God, that phone's been ringing for 30 seconds. That's going to kill my wait time kind of thing. So taking a step back from the metrics, I feel, could also alleviate that stress for a lot of pharmacists as well.
Yeah, I agree. So, actually in California, they have new legislation regarding quotas. Now, Walgreens, CVS, those big companies are finding a way to get through that and little loopholes. So, I mean, legislation is one of the first steps, but that takes time. So, I mean, companies right now can implement no quotas themselves, regardless of legislation. They can go around safe staffing. You know, if you have one pharmacist and one technician, is a vaccination appointment every 10 minutes, is that feasible? Absolutely not. Like Dr. Taylor said, this expanded scope of practice for us is absolutely almost impossible with the work conditions that we're in right now. And so, you know, a start to that is one, quotas and metrics, and another is safe staffing, being able to do what you can safely while you're on the clock.
Thank you, everyone. I think maybe I'll turn to some audience questions now. So please send those in if you're still thinking. I mean, I'll just start with one that was a follow-up on something we've already been talking about relating to closures. David Kroll in the chat was asking how much of the closure issue is due to lower reimbursements versus people buying non-drug items on Amazon or through other discount avenues.
This is Robert. I can, if anybody feels different, I think the closure is more to the number of pharmacists, the individuals. I don't necessarily think it, you know, from the pharmacist walking out or the hours being shorter, it's just people. Having pharmacists there able to have the store open. Now, of course, from the organization side of it, of course, getting into lower reimbursements, and maybe that's why they cut technician hours or something like that. But I think for closures, it's just having the manpower to keep those stores open.
If we were just comparing those two, so lower reimbursements and people buying, you know, non-drug items somewhere else, obviously I don't have numbers, but I would say it's due to lower reimbursements. I always talk with my staff about what can we control, and one of those might be helping with supplements or over-the-counter items. versus, lower reimbursements. You get more income and net profit from those retail items versus just filling a commercial product. So in my opinion, that just comparing those two, it would probably be lower reimbursements are affecting closures more.
Right, here's another question. I am actually quite interested in your responses. Chelsea Patton asked whether any of you have a resource to consult when you believe you are facing an ethical dilemma in your practice. This could be a human resource, it could be some sort of, educational or written resource, or maybe it's just your own, your own moral virtue.
This would probably be a phone a friend. Do you have another pharmacist that you speak with on a regular basis that is working your same schedule that you could call and ask? Otherwise, if it's a really big one, you'd probably want to reach out to something like HR to see how you should handle the situation, depending on how far it is going into that. Where I currently work, we staff 15 pharmacists, and yes, they work every day. So it's very nice. You can always have somebody that you're bouncing ideas off of. Before, when I was the only pharmacist working for a 12-hour shift, it would just be phoning a friend at another Walgreens, or maybe the pharmacy manager that I've never met in person, but speak to every day on the phone at cars across the street, or, whoever I could get a hold of.
Yeah, I agree with Dr. DeVore. So usually it's a phone a friend type thing. We don't have any overlap at my store now, and even at Walgreens we didn't either. So it's typically either I'm going to ask my boss, the owner, and we have a great relationship. So I know I can go to her with any of those dilemmas I might be facing, or I have, I'm still in touch with some classmates from pharmacy school. So I'll go ahead and ask them as well. But, that's a really good question, because we really all should have a resource, maybe more than just something that's asking our friends or colleagues when we're facing something like an ethical dilemma.
Yeah, I mean, my follow-up there was going to be something similar, like, do you find that it's adequate, that your resource is, just phoning a friend, talking to a colleague? I don't think the solution is adding more required training, right, either at the student level or professionally, but yeah, is there a need for some sort of centralized resource or CEU or something you could go to, right, that provides some more structured approach for thinking through these questions? Or is that just adding one more thing, to your plate?
My initial thought is the ethical dilemmas that we face, there's not a clear black or white answer. And so much didactically in school, right? It's the right answer or the wrong answer. I will say, I know some universities, as they let students into pharmacy school, or part of the interview process is asking them these types of questions, to see, there isn't a right or wrong answer, but what's your thought process? Is it definitely not a right or wrong, but you come across and you say, nope, sorry, that's what it is. So I know some universities or schools of pharmacies through that interview process will ask some of those types of questions as well. But I don't think that there's like a great way to do it. I think this is great, having these open discussions and being able to share, right? Because, what Dr. Peterson may experience may be different than my experiences, or Dr. Taylor as well. And so I think just having these open discussions, phone a friend, is the best. I'm not available or, aware of any, great resources out there that we could do a 1-hour CE on or anything outside of, just some more open discussions.
like someone was going to say something there. Dr. Taylor?
Well, and then I saw a hand there, Dr. DeVore, on mute, so I didn't want to step over you. Go ahead if you'd like, and then I'll follow you up.
I'm sorry, I didn't realize that. I was-
Oh, no problem. I just didn't want to go if you had something to say. Gosh, again, I'll just share my opinion. When we're in school, we worry about how we're going to handle these hurdles when we come here. And to me, the biggest resource has not just been consulting with colleagues when there's a problem, whether it's an error or a mistake or a dilemma. But when times are good, like with our students, we'll pull, for example, our audit reports, and I'll show you. I want to show you everything that I've screwed up, so that you can be aware and ready for it and not make the same mistakes. And same thing with these ethical dilemmas that we talk about them. You know, we talk about with our students, with our colleagues, and for me, since graduation, you know, I've looked at other pharmacists and I've seen how they've handled things. And, you know, a lot of these dilemmas are revolving, you know, we run into them again and again, to learn, to see what other folks are doing, other pharmacists. And yeah, I like that. That's great. I'll implement that. Or no, you know what? Gosh, I'm going to handle that differently, and be prepared. And to me, I think the most important is just when something comes up, don't just go with, you know, my immediate thought or reaction, but to think it through and try to make, you know, a non-judgmental, sound response. And that's worked really well for me personally. And I don't get caught up. I'm not as scared or as worried about these dilemmas that arise like I was when I first graduated. So, and that's been helpful for me, is to rely on other folks and to kind of have a plan in place. Because a lot of them, I know there's stuff that's unforeseen and will blindside us, but a lot of them are going to be the same or similar topics coming to us time and time again.
Yeah, and I think, you know, you're all totally right that these are not black and white, you know, questions, and it's more important to have, I think, an approach that you can use to think through these rather than just, you know, some sort of canned response. And yeah. Well, yeah, go ahead, please.
One thing that I would like to add for that is your professional judgment. That's a huge part of it as well. Just your own judgment, as long as you can back it up, as long as you can say, this is why I did what I did, using your professional judgment is going to be the best way to cover you.
And yes, and I know we're out of time, but I just have to add, and that often goes against religious, personal, moral beliefs, but to know that, you know what, you can't let those interfere. We could use them to guide us and to help us, but at the end of the day, a lot of times we have to do what we ideally wouldn't do, and that is often the right answer.
Yeah, and there's an interesting comment here too in the chat. You know, why is it that, you know, physicians and nurses have professional ethics supports, but we don't provide the same services to pharmacies? Yeah, I mean, clinical ethics consultations, right, are huge in the clinical medicine world. And, you know, is there something similar? So should there be something like this for pharmacists to draw on as well? Well, we're at the end. I'd like to thank all of you for joining us and sharing your insights. Also, I want to thank the Skaggs School of Pharmacy and the CU Center for Bioethics again for supporting this program. And thanks to all of the audience members for joining and sharing your comments and questions. Please take the post-event survey, which I believe Malia linked to in the chat. You can let us know what future topics in that survey that you'd like to see us cover in the spring, and hopefully we'll see you at our next event. Thank you, everyone.
Thank you.